Thanks, Dan. Thanks, Matt, for having me. It's a great course. I always learn something. So, Dan, he was one described this, what this was. The top and the bottom of the sockets aren't connected. They're either acute or they're chronic. The acute ones you can fix. The chronic ones have always been a problem. Results have been bad. I can talk from experience. Everything I tried really didn't work very well. It looked good until they took an x-ray a couple years later. Why is it a problem? Because it's a chronic non-union. It doesn't work. There's all kind of debris, cement, bone, metal, and that's why they don't heal and they keep moving around. The ones you see on, I guess, on your left, those are the bad ones. Occasionally you'll see one like you see on the right, but most of them are the up and in defects. And again, when they're up and in, usually the hemisphere has a lot of bone loss and you have to reconstruct the hemisphere. These are all the things that have worked. I can talk from experience because I did all of them and most of them didn't work. So we're going to talk about a distraction in the combination of distraction, but using augments as well. As Brian just eloquently mentioned, CT models can really help when you want to decide, do you want to do what Dave did or do you want to do what Brian did? And a vast majority, I think, can be done without a triflange. But this is kind of, I think this is coined by Matt Abdel. This is an off-the-shelf solution to these complex problems. How do you evaluate it? Define the discontinuity with a Cobb elevator, but don't disrupt the fibrous non-union. That's the key. And make sure it's chronic. If it's acute, you can't do this. Always make sure you know how to understand how to reconstruct the hemisphere. You've got to be able to put the cup in. You have to be able to distract